All right, scrubs on everyone. Today's deep dive is going to be laser focused on helping all you orthopedic surgery residents out there dominate those postgraduate exit exams.
You know it.
We're dissecting the Ortho Made Simple notes put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore.
Oh, nice.
And get this, he aced the FRCS exams just last year.
Oh, that's awesome.
Yeah, so think of this deep dive as your surgical cheat sheet straight from the operating theater. You ready to get into it?
Born ready. Let's go.
All right. Now, as orthopedic residents, you're practically or are veterans by now.
Yeah,
But even seasoned pros need a refresher on the fundamentals.
absolutely. Got to keep those basics sharp.
Exactly. And speaking of fundamentals, when it comes to the OR, nothing is more fundamental than sterilization, disinfection, and cleaning. I mean, we use these terms all the time.
Every day.
But do we really understand the nuances?
That's a good point.
What's the crucial distinction between these three processes? Like what really sets them apart?
It all boils down to the level of microbial obliteration.
Okay, I like that. Microbial obliteration.
Right. So cleaning, that's your first line of defense, just removing that visible dirt and grime.
Right, the basic stuff.
Exactly. Then you step it up with disinfection, knocking out most microorganisms.
Okay.
But sterilization, that's the nuclear option. Complete microbial annihilation.
Need survivors.
Exactly. We're talking eradication of all microbial life, even those stubborn bacterial spores.
Wow. So when we're talking about prepping instruments for surgery, sterilization is the gold standard.
Absolutely. It's non-negotiable.
And the autoclave, that's our workhorse for achieving that level of sterility.
Right. Good old reliable autoclave.
But what about heat-sensitive equipment,
No.
like those delicate scopes, for instance?
Ah, yeah. For those, you got to bring in the big guns.
Like,
Radiation or chemical sterilization. It's like choosing the right weapon for the microbial enemy you're facing.
okay, I'm liking these analogies.
But, there's a question that pops up all the time. How do we actually verify those instruments are truly sterile? We can't just take their word for it, right?
Right. We're talking about people's lives here.
Yeah.
There's zero room for error.
Exactly. So we use a triple check system, mechanical, chemical, and biological indicators.
Oh, okay. A three-pronged approach.
Precisely. Mechanical indicators, those monitor the autoclave's vitals: time, pressure, temperature, making sure everything's running as it should.
Got it. So like a system check.
Right.
What about chemical indicators?
Think of those little heat-sensitive stickers on the packaging that change color when they've been exposed to the right condition.
Oh, yeah, those. Like a visual confirmation.
Exactly. They're like, hey, things are on track here.
Okay, those make sense.
Huh.
But what about the biological indicators? Those sound a bit more intense.
Oh, they are. They're the ultimate test of sterility. We use these tiny warriors, bacterial spores, to challenge the sterilization process.
Bacterial spores.
Yep, like Bacillus, Sterothermophilus,
Good.
super resilient little guys.
Yeah.
So if even those tough spores are obliterated, we know we've achieved true sterility. It's like a microscopic gladiatorial combat, and sterility is the victor.
That's a brilliant way to put it. Okay, speaking of combat, let's move on to another essential OR tool, the tourniquet.
Ah, the tourniquet.
It's not just a matter of strapping it on and hoping for the best.
Oh,
right?
no, not at all.
There's a whole science to it.
Yeah,
I'd imagine knowing those nuances is going to be make or break for those exams.
absolutely. Tourniquet application is a delicate balance, between achieving hemostasis and preventing complications.
Okay, right.
And it starts with picking the right size. Too narrow, and you risk compressing nerves. Too wide, and you might not be able to control the blood flow properly. The general rule of thumb: choose a cuff width that's as wide as possible without overlapping the surgical site.
So size matters.
Absolutely.
And once we've got the right size, what about setting the pressure? Is there like a magic number we should be aiming for?
Not really. No magic number here. The goal is to use the lowest effective pressure for the shortest possible time. We take things into account like the patient's age, their medical history, and which limb we're operating on.
So a lot of factors in play.
And remember, time is tissue. The longer the tourniquet is on, the higher the risk of complications. Gotta be vigilant about those time limits.
Okay, vigilance is key.
Yeah.
And speaking of complications, let's talk about those two syndromes every orthopedic resident needs to know for their exams: post-tourniquet syndrome and tourniquet paralysis syndrome.
Yes, those are high-yield topics for sure. Post-tourniquet syndrome, that's usually temporary. It happens because of ischemia followed by reperfusion. So you might see things like edema, stiffness, and some weakness.
Okay, temporary, that's good. But what about tourniquet paralysis syndrome?
No, that one's a different story. We're talking flaccid paralysis and sensory disturbances.
Oh, wow.
And it can even be permanent. It's caused by direct nerve compression. So patients with diabetes or peripheral neuropathy, they're particularly vulnerable to this one.
So knowing those risk factors and how it presents clinically, super important for those exams.
Absolutely essential.
Now, let's shift gears and talk about another OR staple. Sutures.
Sutures.
There are so many different types: absorbable, non-absorbable, braided, monofilament. It's enough to make your head spin. How do we choose the right suture for the job? What are the must-knows for those exams?
Picking the right suture, it's like choosing the perfect tool from a well-stocked toolbox. Absorbable sutures, like your Vicryl or PDS, those are your go-to for internal tissues. The ones that don't need permanent support. They break down over time, no trace left behind.
Okay, kind of like those biodegradable shopping bags.
Exactly. And then you have your non-absorbable sutures. These are your heavy lifters. Your nylon, your Prolene, those are the ones you use for things like skin closure or tendon repair. Think of them as the steel beams of the suture world.
And what about braided versus monofilament sutures? What are the pros and cons there?
Great question. Braided sutures, they've got excellent knot security because of all those intertwined strands.
Okay, that makes sense.
But they do have more tissue drag, and the risk of infection is a little bit higher.
Gotcha. So what about monofilament?
Monofilament sutures, they're smooth operators. They glide through tissue easily, and the infection risk is lower, but those can be trickier to tie securely.
So it's all about trade-offs.
Always.
Speaking of trade-offs, how am I supposed to remember how long each of these sutures takes to be resorbed? I'm sure that's going to be on the exam.
You're right, those numbers are important. Here are a few key ones to commit to memory. Monocryl provides wound support for about 20 days and is fully resorbed within 3 months.
Okay.
Vicryl sticks around a bit longer, about 30 days of support, and resorbs in roughly 2 months.
Got it.
And then you have PDS, that's the marathon runner of absorbable sutures. It supports the wound for a whopping 60 days and takes a full 6 months to be completely resorbed.
Okay, let me see if I got that. Monocryl, 20 days, 3 months. Vicryl, 30 days, 2 months. PDS, 60 days, 6 months. I think I can remember that. Okay, let's get energized and talk about diathermy.
Now we're talking. Diathermy, this fascinating stuff, harnessing electrical current to stop bleeding and cut through tissue.
I'm intrigued.
But first, we need to clear up a common misconception. Electrocautery versus electrosurgery. They sound really similar,
They do?
but they work in very different ways.
Okay, I'm all ears. Explain it to me like I'm 5.
All right, so imagine you've got a piece of paper you want to cut. Electrosurgery, that's like using scissors. The current passes directly through the tissue to cut or coagulate it.
Okay, scissor.
Electrocautery, that's more like using a hot iron. It uses direct current to heat up a probe, and that heat is what affects the tissue. No current actually flows through the patient.
Oh, that makes so much more sense. Okay, so diathermy falls under electrosurgery, right?
Well,
And it uses alternating current.
you got it.
But what about all those different diathermy modes? Coagulation, cutting, blend, fulguration. What's the deal with those?
Each mode uses a different waveform to get a specific effect on the tissue. Coagulation uses interrupted pulses to create a square waveform, which heats the tissue and stops the bleeding. Cutting mode uses a continuous current, so a sine waveform, and that vaporizes cell water, basically allowing you to cut through tissue.
Makes sense.
Then you've got blend mode, which, as you can guess, combines both cutting and coagulation, giving you the best of both worlds. And then there's fulguration, which is a bit special.
Here's where it gets really interesting, right?
Fulguration is all about creating a controlled charring of the tissue.
Okay.
It uses a coagulation waveform, but here's the twist. The electrode is held a bit away from the tissue,
Oh,
creating an electric arc. It's almost like tiny little lightning bolts.
that's incredible. But obviously safety is paramount when you're working with electricity. What are the big things to keep in mind when using diathermy?
You're absolutely right. We're talking surgeon safety, diathermy plate safety, and patient safety.
Wow. So a lot to consider.
For sure. For the surgeon, always put that diathermy back in the holster when you're not using it.
Right. Safety first.
Exactly. And avoid applying monopolar diathermy to the ends of appendages, like fingers and toes.
Okay, why is that?
Those areas have poor blood supplies, so they're more prone to burns.
Makes sense. What about the diathermy plate? What do we need to know about that?
The plate, or the indifferent electrode, as it's sometimes called, it's a key part of the circuit. It's got to be placed on a large area of hairless skin, no wrinkles or air gaps to make sure there's good contact and prevent burns.
Right. So placement is key.
And you also want to position it away from the heart, but as close to the operation site as possible, and never, ever let flammable fluids pool around the plate.
Okay, that's a recipe for disaster.
Exactly. Now, for the patient, you absolutely have to remove all metal objects, jewelry, piercings, everything. Metal can concentrate the current and cause some serious burn.
Okay, good to know.
And then there's the special situation of patients with pacemakers.
Oh, yeah. I imagine it gets a bit tricky. How do you manage a patient with a pacemaker when you need to use diathermy?
It requires careful coordination with the cardiology team and the anesthesiologist. Ideally, you'd switch the pacemaker to asynchronous mode to prevent interference from the monopolar diathermy.
Gotcha.
During the surgery, bipolar diathermy is the way to go, if at all possible. But if you have to use monopolar, use it in short bursts and stop immediately if you see any arrhythmias. And always, always have a magnet on hand.
Okay, a magnet. What for?
It can activate the asynchronous mode if you need to, forcing the pacemaker to pace regardless of the patient's own rhythm.
Okay, that makes sense. So what's the difference between bipolar and monopolar diathermy?
In monopolar diathermy, the current flows from the active electrode through the patient's body and back to the diathermy machine through the return electrode, that plate we talked about. It's like a big loop.
Okay.
Bipolar diathermy, on the other hand, keeps the current localized between the two tips of the forceps. No need for a separate return electrode. It's like a tiny self-contained circuit.
I see. So bipolar is generally safer then, especially for patients with pacemakers. Are there any downsides to using bipolar diathermy?
One thing to keep in mind is that bipolar only has a coagulation mode, there's no cutting mode. So it's great for hemostasis and delicate procedures, but if you need to cut through thick tissue, monopolar might be a better choice.
Okay, good to know. Now, one last diathermy-related topic I want to touch on. Radiofrequency ablation, or RFA. What is that exactly, and how is it different from traditional diathermy?
RFA is another technique that uses electrical current to destroy tissue, but it's typically used for things like tumor ablation or pain management, not really for cutting or coagulating during surgery. One key difference is the scope solutions used for RFA and diathermy. For diathermy, we usually use water as the irrigation fluid, but for RFA, normal saline is the go-to.
Why is that?
It has to do with how the current flows. With traditional diathermy, the current passes through the patient's body, so saline, which is a conductor, would create a risk of burns. But in RFA, the current is localized to the probe.
Okay, that makes sense.
So the saline doesn't interfere with the process. In fact, it actually helps conduct the heat away from the surrounding tissues, making it safer and more precise.
Wow, so the same solution that's a no-no for diathermy is actually beneficial for RFA. It's all about understanding those mechanisms.
You got it.
And that actually wraps up part 1 of our OR deep dive. We've covered a ton of those high-yield essentials you need for your postgraduate orthopedic exams. Make sure to check out Dr. Mok Ying Ren's full OrthoMade Simple notes on mokyingren.sg to really dive deep into these topics. We'll be back soon with part 2, where we'll be tackling optimal OT design and those pesky surgical site infections. Stay tuned.
Definitely. See them.
And we're back for part 2 of our OR deep dive. We're getting into another critical topic for your postgraduate exit exams: designing the optimal operating theater.
It's more than just making sure things are clean, right?
Exactly.
Yeah.
So what are those key design features that really make a difference? What do we need to know?
It's kind of like orchestrating a symphony, you know?
Oh, okay.
Every element has to work in harmony to create an efficient and sterile OR. And the location itself, that's our first consideration. Ideally, we want the OR close to the ER and radiology.
Makes sense. You don't want to be wasting time transporting critical patients.
Exactly. Time is tissue, especially in those emergency situations.
Absolutely.
Yeah.
Okay, so we've got the perfect location. What about the layout of the OR itself? How do we design that space strategically?
Well, we're not just throwing things together randomly.
Right.
We use a zone system to minimize the risk of contamination.
A zone system.
Yeah, think of it like concentric circles, with the surgical field at the very center.
Okay.
That's the most protected zone of all. You've got the outer zone, the clean zone, the aseptic zone,
Yeah.
each with its own level of restriction.
Interesting. So it's all about creating those layers of protection.
Exactly. Now, what about things like lighting, temperature, and humidity? Do those really matter?
I mean, they seem important for patient comfort, but do they actually impact surgical outcomes?
Oh, they absolutely do. Proper lighting is crucial for visualization. We want it bright, but not blindingly bright.
Right.
At the surgical site, the ideal illumination is around 40,000 lux.
Wow. I never realized there was a specific number for that.
There is. And then temperature and humidity, we need to find that sweet spot for patient comfort and infection control. Think 18 to 23 degrees Celsius and 30 to 60% humidity.
Okay, so cool, dry, and comfortable.
Exactly. For everyone involved.
All right, that makes sense. Now let's talk about ventilation. I've heard a lot about laminar flow systems. Are they really as good as they sound?
Laminar flow, that's a big one. It's all about creating this unidirectional flow of ultra-clean air over the surgical field. Imagine a gentle, invisible shield pushing away those pesky microbes.
Like a sterile air curtain.
Exactly. But, the evidence supporting their effectiveness is a bit mixed.
Really?
Yeah, some studies have shown a benefit, but others haven't found a significant difference in infection rates compared to other systems.
Huh. So laminar flow might not be the magic bullet we once thought it was.
Might not be. But that doesn't mean we can ignore air quality altogether. We still need to make sure that OR air is clean.
Right, of course. So how do we monitor that? How do we know if the air meets those sterility standards?
We've got two main strategies: passive and active monitoring.
Okay, tell me more about those.
Passive monitoring, it's kind of like setting out microbial traps.
Microbial traps, what does that even mean?
We use settle plates, Petri dishes filled with growth media, and place them around the OR.
Okay.
And any airborne bacteria that happen to be floating around will settle down and will grow. Then we analyze those plates, count the bacterial colonies, and that gives us a general sense of the air quality.
So it's like a microbial head count.
Exactly. Active monitoring is more like a microbial dragnet. We actively suck in a specific volume of air and trap any microbes for analysis.
Oh, so it's more precise than passive monitoring.
Yeah, we get a more accurate measurement of the bacterial concentration in the air.
Got it. So passive monitoring is like a general checkup, and active monitoring is a more targeted investigation. You got it.
Now, once we've created that pristine OR environment, it's time to prep ourselves for surgery.
Right, got to get ourselves sterile.
Exactly. So what are the best practices for turning ourselves into sterile superheroes? What's the deal with the surgical scrub?
Ah, the surgical scrub. It's more than just a quick hand wash, that's for sure. We want to eliminate as many microbes as we can from our hands and arms, creating that first line of defense against contamination.
And what's the best way to do that? Chlorhexidine? Iodine? Something else?
We've got two main contenders, chlorhexidine and iodine. Both are great, but chlorhexidine has a slight edge in terms of its long-lasting effects.
Oh, interesting. So chlorhexidine is better for those longer surgeries.
Pretty much. Now, what about alcohol-based rubs? Have you heard of those?
Yeah, but are those really good enough for surgical scrubbing?
They are. Research has shown that they're just as effective as traditional scrubs when it comes to reducing bacterial counts.
Oh, who knew?
Plus, they're faster and easier to use, which is a bonus.
Right, every second counts in the OR.
Okay, so we've scrubbed our hands to perfection. Now it's time to get dressed for the occasion. What's the ideal attire for the OR?
Well, those classic cotton gowns, they're comfy, but they're not the best at keeping bacteria out. We've moved towards disposable, hydrophobic gowns made of non-woven polyester.
Oh, so those are better at preventing contamination.
Much better. They're like our microbial armor. Think of it like an impenetrable barrier against those pesky bugs.
Microbial armor, I like it. Now, what about those spacesuits I've seen in some ORs? Are those just a gimmick, or do they actually work?
Those spacesuits, or body exhaust suits as they're sometimes called, they're an interesting concept. They create a sealed barrier between the surgical team and the patient.
Okay.
Essentially putting the surgeon in a sterile bubble.
That's pretty wild.
It is. But the research on their effectiveness is still a bit iffy. Some studies show benefits, others don't. The jury's still out on that one.
So the debate rages on. But the bottom line is, choosing the right surgical attire is crucial for maintaining a sterile environment.
Absolutely. It's all about minimizing that infection risk.
Which brings us to the enemy we all face in the OR surgical site infections.
Ah, yes, those pesky infections.
Definitely a high-yield topic for those exams.
For sure. But the good news is we've got a multi-pronged approach to combat them. Pre-op, intra-op, and post-op.
Okay, let's break it down then. What are the most important pre-op considerations? How do we set the stage for an infection-free surgery?
Pre-op is all about preparation. First, we screen patients for any potential sources of infection, like MRSA.
Yeah.
And if we find something, we can implement decolonization strategies, like antimicrobial washes.
So we're basically starting with a clean slate, right?
Exactly. Then during the surgery itself, we've got all those sterile techniques we've been talking about. Or design, ventilation, scrubbing, gowning, and don't forget those iodine-impregnated drapes. Those create an antimicrobial barrier around the surgical site.
Right, like iobond drapes, for
Yeah,
instance.
those are a good one. And then there's double gloving.
Double gloving, why is that so important?
It adds an extra layer of protection in case a glove gets punctured.
Oh, that makes sense. What about skin preparation solutions? What do we use for that?
Usually a combo of chlorhexidine and alcohol, but if we're working near a mucous membrane, povidone iodine with alcohol is a better choice.
So it seems like barriers are a recurring theme here, creating multiple layers of protection to keep those microbes out of the surgical site.
Exactly. Now, what else can we do to minimize contamination during surgery? What do you think?
Well, we need to minimize traffic in and out of the OR. Right.
You got it. Every time someone enters or exits, they're potentially bringing in contaminants.
That's true.
So we really need to control that flow of people and make sure everyone is following those scrub and gowning protocols.
Like we're guarding a sacred temple of sterility.
Exactly. Now, one more intra-op factor to think about. Blood transfusions. They can be life-saving.
Absolutely.
But do they also increase the risk of infection? What do you think?
That's a good question. I don't know, actually.
Well, the answer is yes.
Oh, why is that?
It's likely due to a few different things. You've got the immunosuppressive effects of transfused blood, and there's always the possibility of introducing contaminants during the transfusion itself.
So it's a balancing act. Blood transfusions can be life-saving, but they do come with some inherent risks.
Exactly. Now we've covered pre-op and intra-op. What about post-op? How do we prevent infections once the surgery is over?
That's where the recovery process starts, right?
Exactly. Post-op care is all about vigilance. We keep a close eye on those wounds, looking for any signs of infection, redness, swelling, drainage, anything suspicious. And impeccable wound care is paramount.
So close observation and proactive wound care. Makes sense. But what about those antibiotic-resistant bacteria, like MRSA? How do we stop them from spreading?
That's a tough one. Proper patient cohorting is crucial. Isolating patients who are known to be colonized or infected with MRSA, preventing transmission to others. And then, of course, you've got those basic principles of infection control that we drill into everyone. Hand hygiene, PPE, environmental cleaning.
Right, those foundational practices that we can't afford to forget.
Absolutely. It's a constant battle, but we have a lot of tools at our disposal.
That's good to hear. So we've covered pre-op, intra-op, and post-op strategies for tackling surgical site infections. That wraps up part 2 of our deep dive, all focused on that must-know information for your orthopedic exams. Don't forget to check out the full Ortho Made Simple notes on mokyingren.sg.
Absolutely. Lots of great information there.
We'll be back soon with part 3 to wrap things up and leave you with some final pearls of wisdom. Don't miss it.
See you then.
And we're back, the final part of our OR deep dive.
Can you believe we're already here?
I know, right? Time flies when you're having fun dissecting surgical practices.
It really does.
But before we get to those final pearls of wisdom, I want to circle back to something we talked about earlier. How can we actively engage patients in their own care? Empower them to be part of the process.
That's huge, yeah. It's a crucial part of modern surgical practice, for sure.
It really is. I mean, patients who are informed and engaged, they're more likely to follow post-op instructions.
Absolutely.
They can recognize any red flags early on, and overall, they just have smoother recoveries.
100%.
But how do we actually achieve that level of engagement? We can't just hand them a stack of pamphlets and hope for the best.
No way. It all starts with communication. Clear communication.
Okay, so explain things simply, avoid jargon.
Exactly. And really listen to their concerns. It's about building a connection.
Building trust, making them feel heard.
Exactly. It's a partnership, not a dictatorship.
I like that. And I bet technology plays a big role in all of this, right?
Oh, absolutely. We've got all these incredible digital health tools now.
Like
Symptom tracking apps, wearable devices that monitor vital signs, online platforms for personalized education.
So it's like having a virtual health coach right there in your pocket.
Pretty much.
It's amazing. But with all this new tech, how do we make sure patients aren't overwhelmed? Lost in a sea of information.
That's a great point. We need to be their guides through this digital landscape, help them pick the right tools.
And make sure those tools actually integrate with our existing care pathways.
Exactly. And we can't forget about data privacy and security.
Right. Those are essential considerations.
Absolutely.
So it's about using technology strategically, thoughtfully, not just because it's shiny and new.
Couldn't have said it better myself.
Now, let's talk about another critical aspect of surgical care. Minimizing complications.
Oh, yeah. That's always top of mind.
We've already talked about surgical site infections in depth, but what are some other common complications we need to be on the lookout for?
Bleeding, nerve damage, DVT, those are always on our radar.
Okay, so pretty serious stuff.
Absolutely.
So how do we approach this whole challenge of minimizing complications? Is it just about being a surgical rock star, or is there more to it than that?
Surgical skill definitely matters, but it's just one piece of the puzzle.
What else is there?
It's a multi-pronged approach. You need to be careful with patient selection. Meticulous preoperative planning,
Right.
flawless surgical technique,
Okay.
and eagle-eyed postoperative monitoring.
Okay, so let's unpack that. What do you mean by careful patient selection?
Not every patient is the right fit for every surgery. We need to evaluate their overall health, their medical history, those risk factors,
Yeah.
and determine if surgery is truly the best option. Sometimes a non-surgical approach might be better.
So it's about choosing the right treatment for the individual.
Exactly. Right patient, right treatment, right time.
And preoperative planning, how do we go about that strategically?
It's all about preparation. Reviewing those imaging studies, mapping out your surgical approach, anticipating any potential challenges, and making sure you've got all the right tools and resources.
So it's like prepping for a big battle.
Exactly. You got to have a plan.
Okay, and then once we're in the OR, meticulous surgical technique takes center stage.
Precision, gentleness, respect for those tissues.
Right, it's not just about speed.
Nope. We minimize trauma, control bleeding carefully, avoid any unnecessary fiddling around,
Got it.
and, of course, always be aware of the surrounding anatomy.
You don't want to be nicking anything important.
Exactly.
So it's like a dance, a delicate dance between artistry and precision.
That's a beautiful way to put it.
And even after the surgery's done, that vigilance doesn't stop, right?
Yeah.
We still need that eagle-eyed postoperative monitoring.
Oh, absolutely. We're watching those patients like hawks, checking vitals, looking for any signs of bleeding or swelling.
Making sure those pain levels are under control, assessing neurological function.
Yep, all of that. Early detection is key.
It's like a 247 surveillance operation to prevent those complications.
Pretty much.
Now, just a reminder, all of this amazing information is based on Dr. Mok Ying Ren's OrthoMade Simple Notes. You can find those on his website, mokyingren.sg.
Such a valuable resource.
They really are.
Yeah.
Now, before we sign off, I want to speak directly to our listeners.
Okay.
You're the future of orthopedic surgery,
Bright minds, eager to learn.
and you're about to embark on a challenging but incredibly rewarding career path. What words of wisdom would you offer them as they navigate the complexities of surgical training and practice?
Let me think. First and foremost, never stop learning. Medicine is constantly evolving, so stay curious. Embrace that lifelong learning mindset.
That's so important. Never be afraid to ask questions.
Exactly. And don't forget those communication skills. Surgery is a team sport. You need to be able to communicate clearly with your colleagues, nurses, and of course, your patients.
And never underestimate the power of empathy.
Couldn't agree more.
Those are words to live by, not just for surgeons, but for all of us in healthcare.
Well said.
And with that inspiring message, I think it's time to wrap up our OR deep dive.
It's been a pleasure sharing this journey with you and our listeners.
Thank you all for joining us on this exploration of the operating theater. We'll be back soon with another deep dive into a brand new topic. Until then, keep those scalpels sharp and those minds curious.